Welcome to The Whole Pineapple. I'm Ruby Booras.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Hello, pineapple people. Welcome to this episode. You're here, you've been with us, and hopefully will continue to stay with us. New listeners, thank you for joining. We hope that we can provide you some good, reliable information today, particularly because of the topic that we have today is a challenging one. Arguably one of the most challenging fertility issues that we deal with.
Definitely. When I'm so happy that we have our guest here today because she's someone who is so well known in this field and we're really excited, and also a known podcaster. So we're excited to have her on to talk with us today.
And also just happens to be our neighbor across the pond, or Lake Union in Seattle. All right. Well, we are talking about recurrent pregnancy loss today, and I am so delighted to welcome Dr. Lora Shahine. Dr. Shahine is a physician, double board certified in reproductive endocrinology and infertility and obstetrics and gynecology. She graduated medical school at Wake Forest University's School of Medicine, residency in OB/GYN at UCSF, and fellowship in REI at Stanford, where she served as a clinical instructor in the Department of Obstetrics and Gynecology. Dr. Shaheen has trained in one of the few centers for recurrent pregnancy loss, so we have a resident expert here, and has published over 50 peer-reviewed research projects, numerous articles, several books, which include Not Broken, An Approachable Guide to Miscarriage and Recurrent Pregnancy Loss, Planting the Seeds of Pregnancy, An Integrative Approach to Fertility Care, and a children's book titled The Bean Family Sprouts, Growing Stronger Through New Experiences, which looks adorable, I have to say.
That's great. I didn't know about the children's book. We'll have to add that to our episode because we're planning to do a book review of children's books that relate to fertility stuff. So that's perfect.
Oh, yeah. And you've probably seen her around because she has a robust social media presence, over 300,000 followers, probably more now, and across all the platforms and counting. And she is the host of the podcast Baby or Bust, which explores the fascinating world of fertility. That's the abbreviated version anyway. So welcome to the show.
Oh, thank you so much. What an honor to be here. And I just really appreciate that introduction. I'm blushing.
Oh, it's so fun. And you put out such great information for people that are struggling with fertility or just interested in the field. And it's just so nice to have like an actual, somebody that it works in the field to give reliable information.
Oh, thank you. I really enjoy educating. I come from a long line of educators and teachers in my family. And I think that's one of the fun things about being a provider, as you guys know, is working with patients.
Me too.
Yes, for sure.
And so that's what social media and being an author is to me. It's a different way of educating, and I just love it.
I think Ruby and I both talked about how some of the hardest technical visits are when we have a patient that says, I don't want you to tell me what's going on with my ultrasound or my HSG. I just want you to be quiet because it's so hard for me to not explain what I'm seeing and what I'm doing. I want to help everybody understand what we're doing. So
yes, exactly. I'm the same way. I just love it.
Well, I'd like to start off by just kind of asking people how they got into this area. So when you were first looking at medicine, what drew you to reproductive medicine? And then how did you end up focusing so much on pregnancy loss?
Even just in medical school, I was just a big nerd and just loved everything. And so obstetrics and gynecology focused on women's health, but you could do surgery and care for people for a long time. So I was drawn to that. I didn't really get a lot of exposure to infertility until I was in residency at UCSF in San Francisco. And I was just like, oh my gosh, I love the technology. I love the education. I love the support. I loved helping people build families. I was just like, how can you not do this? This is incredible. And very fortunate to match it fellowship at Stanford, and really had an incredible experience there. And while I was there, my mentor, Ruth Lottie, opened her Center of Recurrent Pregnancy Loss at Stanford. And so just being in that environment and learning her goal of really making it an integrated approach to care. So meeting with immunologists and researchers and hematologists and just every ologist that you can to learn how this area, miscarriage and reproduction in general, it's still, we have so much to learn, and how all these different disciplines can come together and help. And so, not my intent, but when I came up and opened up my practice in Seattle, there's incredible healthcare here, but there wasn't really anybody focused on recurrent miscarriage. I'm pretty old, so this is like back in 2009. And so I was like, I think I could really help. And I certainly do not assume to know everything, but just really opened up my own center here and just try to be a resource to the community about this thing we call miscarriage and recurrent miscarriage. And it's been a journey.
Well, I think the fact that you do have such a holistic approach, I mean, that's certainly one of the things that we admire so much and try and connect with what we're doing with the podcast, because it's an area where there's so many unanswered questions and people want answers that we don't have. And people are looking for like, well, what could I do? What can I be doing?
And we want to be able to offer something, that we can do, something that we can control. One of the fascinating but also frustrating parts about this field is that there is so much that we don't know. And we do oftentimes fall in this kind of gray area. I wish I know some stuff. It's very high tech in certain ways, but then in certain ways we don't know anything.
Yeah. Well, not having your family when you're ready already is a sense of being out of control. Whether it's a menstrual cycle that you weren't hoping for, or a failed IUI, or miscarriage after an embryo transfer, it just compounds that grief and that lack of control. But the longer I do this, the more humble I get, the more I realize that I don't know everything, but yet the vast majority of people that are having miscarriages go on to have their baby. Like, there's so many things that are going right. The egg and sperm like each other, the embryo is implanting, and truly it will happen if we can provide, we don't want to miss anything. We want to do testing and make sure we're not missing something that we can control. But I think providing that support and that reassurance and ability to encourage them to keep trying can be one of the best things that we can do.
I think that's so true. And that's one of the things that I've noticed too, now working in this field for 14 plus years, is I feel like the more I'm here, it's just like the disconnect, because I feel overall helpful for people who feel completely not helpful for themselves. And it's I feel like I felt more of that the longer that I work here, because I have this mental memory of all these people that I've seen that were so convinced that it wasn't going to happen for them. And I've seen them get to that other side. And so I feel like it is a weird situation, because in so much of infertility, we're having to temper expectations. But this is an area where sometimes we feel like someone's a better prognosis than they see themselves as. So
that's a great way to put it, Anne. Exactly.
Well, let's break it down a little bit. For our listeners who may not know as much about the topic, what does it mean to say that someone has recurrent pregnancy loss or recurrent miscarriage?
A lot of patients assume, or they even hear from providers, that they can't do testing or they don't meet the diagnosis of recurrent miscarriage unless they've had 3 miscarriages. And a lot of people or patients or providers will exclude biochemical miscarriages or kind of early losses. So it kind of gets confusing, but actually ASRM, the diagnosis of recurrent miscarriage, is 2 or more pregnancy losses. And even just as recently as 2020, they removed the word clinical miscarriage from the definition, which means that you get to the point in the pregnancy where you can actually see something on ultrasound. And so they have just over the years liberated that definition. So if you have been pregnant more than once and it has not resulted in a baby, technically 2 or more losses, that is recurrent pregnancy loss. And you should consider asking for an evaluation, making sure that you're not missing anything.
And would that include even someone that had a positive home test and then got a period? You don't even have to have a blood confirmation.
It's still a loss, right?
It does in my book. Why do I deny people testing if I'm super honest with people and say, listen, the most common cause of miscarriage is something within that embryo. And biochemical miscarriages, and that means, like you described, like a positive pregnancy test that a late period. It doesn't continue to the point where you can do testing on the embryo to see a chromosomal issue. We know even less about them, but it just makes sense to me that could probably be an embryo issue. But why wait for more miscarriages or a later loss to find an anatomic issue, a thyroid issue, something that you could help? But very honest, I'm like, hey, listen, we're probably not going to find anything. And quite honestly, you probably just need to try again. But that's a different way of saying it than, oh, you don't meet criteria, get out of my office.
For sure. And so many people feel like then if they do have another loss, then they feel even more like, see, I should have done testing before. You made me go through this whole other experience. I think that's part of what sets up so much strain and stress every time someone's get pregnant, because it's like they feel like they were forced to go through an experience before they could even begin to figure out if there was something else going on.
Yeah. And it's that compounded loss, like you had mentioned.
Yeah. And I can sit back, and you guys can too. And we've been in this and helping people for so long. We know how common miscarriage is. We know how inefficient human reproduction is. Even when they were trying to figure out how to do home pregnancy tests, like get them into drugstores, there was this guy at the NIH that he was called Dr. Urine, because he was collecting urines from all over the country and people who were married, because back then, people didn't have premarital intercourse, right? They were married, they were not using contraception, and he would just check their urine once a month. And they were actually really conflicted about putting pregnancy tests on the shelf because of how many biochemical pregnancies people have. And they didn't think women could handle this information. It's hard because we still need to collect the data, and a lot of people aren't reporting biochemical miscarriages, but I think it's like so much more common than what people realize. And so you have a couple of those when you're trying, and you automatically think there's something wrong with you because nobody ever told you that this could happen.
Especially, I think, because so many people are posting a positive pregnancy test on social media and just like, and then I had a baby. There's sort of this assumption that positive test equals baby in 9 months. And there's so many things wrong with that. I think a lot of people don't understand how inefficient reproduction is and how common, especially when we're talking about these really early losses, things are.
Even when things are common, like biochemicals and miscarriage, it doesn't mean they're any less hard. It just means that we don't talk about them as much. And there are other people, lots of other people have gone through the same thing.
Exactly.
What are the main things that you're like looking for when someone starts doing a workup? Obviously the anatomical issues, but do you want to talk a little bit more about what you're specifically looking for?
You do some sort of uterine cavity evaluation to make sure there's not a fibroid that's in the uterine cavity. Like fibroids are so common. 50% of people with a uterus will have a fibroid, but most of them do not cause miscarriage. But you want to look and see if there's one in the uterine cavity that could affect implantation of the embryo. You look for the one thing that you could be born with. It's just called a uterine septum. It's like a fibrous band of tissue in the middle of the cavity that, again, could affect implantation. So those are the anatomic things that I really look for. The one genetic thing that both partners should be tested for is something called a blood test for a karyotype. And you're looking for something that's so rare. It's like less than 3% of people with multiple miscarriages. It's called a balanced translocation, but it's something that could be in the genetics of the people that are getting pregnant. It doesn't impact their health. That means that either if it's the male partner, not all of the sperm is going to be perfect. And if it's a female partner, not all the eggs are going to be perfect. So it can just explain why, especially like a young couple is having more miscarriages than you would expect. The one immune issue that has been associated with recurrent miscarriage is something called Antiphospholipid Syndrome. That too is very rare. It's very hard to diagnose. It's a collection of clinical findings as well as multiple lab tests, but I look for that. You do screen for certain hormonal things like elevated prolactin, thyroid issues. I screen for blood sugar control. I have actually diagnosed outright diabetes in young, healthy women.
Yeah, I have too. And it's always like, whoa.
Yeah.
And sometimes I've had some pretty overt diabetes. I'm like, well, we have something we have to deal with. We have an answer probably, so.
Yeah. And it's so great that you found this while you were young. It's a shock, but I'm so glad we figured it out. And so those are the main things. But that's exactly why I wrote the book, Not Broken, is because we have the luxury of having like 30 minutes, maybe an hour with patients, but they can't retain everything.
Right.
So I go through this and then I'm like, okay, and then here's the book. Like you can read what we're testing for because it's just hard to retain.
Oh, yeah. We talk so much at those visits, and I know that patients are not hearing most of what I'm saying. I'm like, but I have to talk anyway. Well, one, because I can't help myself.
Most important thing is what you said at the beginning, letting them know the most likely outcome is we don't find something. We're going to do all this testing, but
what is it, like 50 or 60% is just nothing?
You're exactly right. That's what the data says. I feel like in my own practice, I'm finding even more people that don't have a clear-cut answer. And I just believe it's because the issue is, again, within the embryo. And you can't, when you're testing the typical test to evaluation for recurrent pregnancy loss, you're testing the people that are getting pregnant. You're not testing the embryo. So you don't want to miss something, but just most often you don't find this like one factor that's going to change everything. I wish we were. I sort of say, I'm sorry, but
Yeah.
We're probably not.
So what do you say? I've heard some people talk about before the whole theory that the problem is that you have someone that actually is a little bit too receptive, that they get pregnant like with every embryo and that their uterus is like not as selective as it should be. And that's why you keep having these really early losses. Like it's
very happy, excited uterus.
Exactly.
And we have some of these people like, oh yeah, I'll get pregnant every month I try. I'm deliberately not trying right now because I want to get some testing because I've gotten pregnant every time I've tried. And especially working in an infertility clinic, that's so different than our typical patient population that it could be a little hard.
My problem's not getting pregnant, it's staying pregnant. I've heard that several times too.
Exactly. And that's an important part of getting a history and talking to your patients is, okay, you've had 3 losses, but how long does it take you to have a positive pregnancy test? Because I think about people very differently who are conceiving very easily, like within 1 to 3 cycles, versus somebody who's had 2 miscarriages, but it's over a year and a half. Like that's really different. And so for the people that do conceive, like the patients you're describing, I say your superpower is getting pregnant. We know just from doing IVF for 50 years and for helping people conceive, most embryos are not perfect. And so if your uterus is just so receptive and you're just accepting any embryo that comes along, you are similar to someone who has, in air quotes, infertility or not getting pregnant. Neither of you have a baby at the end of a year of trying. And your journey has just been different. That person is so frustrated because they've never seen a positive pregnancy test. And you still don't have a baby, but you're getting this like roller coaster ride of, oh, I'm pregnant. Is it going to stick this time? And I kind of say, I don't have like great data and studies, but it's great that you're having this opportunity because the next time you get pregnant, the most likely thing that'll happen is you have a baby. You don't feel that way, but like really, truly. And then one option is to just absolutely keep trying, or just you got to take the whole patient into picture. But sometimes people say, well, would IVF help? And I'm like, well, I'm not sure, but a benefit of IVF is you can select for embryos that have a normal chromosome content or they don't have a rearrangement. And for those people, it might decrease your time to a baby.
Because for a lot of patients that have dealt with loss, it's although the eventual goal is you want to take home a baby, a lot of people trying to decrease the chance of another loss is like as much or sometimes even people more important. They're like, I just can't keep going through this every month. Everything I could do to improve the odds that the next time I see a positive test, it might be an ongoing. I mean, that's a huge emotional thing. And I do think it's important to bring up what you mentioned for the timelines, because it still shocks me when I see patients that get referred to us who have been trying for multiple years, like, oh, but I had a miscarriage. So my doctor said that reset my clock and I should try for another 6 months or another year. So realizing that when we talk about seeing somebody after 6 months of trying or after a year of trying, that means if you haven't had an ongoing progressing pregnancy, and that having a miscarriage doesn't mean you have to reset that time clock.
I agree completely.
If somebody's pregnant and you're diagnosed with, unfortunately, you've had another miscarriage, but they haven't passed that pregnancy yet, we can do testing on the tissue of that pregnancy. How beneficial do you think that testing is for patients that have had more than one miscarriage, or even if this is their first miscarriage?
What you're talking about is testing the pregnancy tissue for chromosome rearrangements that could explain why they had that miscarriage. And I think everybody should get that testing done. It doesn't mean that they always do. I don't think it matters if it's your first miscarriage or your multiple miscarriage, because every pregnancy is unique. And every time it's a new egg and it's a new sperm, And it doesn't mean that it necessarily changes your path. But if you get that information, then you know, okay, that is why I had that miscarriage. It wasn't the glass of wine I had before I knew I was pregnant. It wasn't the intercourse, the partner is worried, oh my gosh, we had intercourse last week and then we had a miscarriage. It must be my fault. Or just all of the mental gymnastics that you do, you get that information. But I always say, like, even if it comes back that the chromosomes are matched, like you don't get that answer, that does not mean that that was a normal embryo. So you can't get a normal, big air quotes. I hate the word normal in our field because, like, what is normal?
I hate the word normal. And I hate the word failed. I hate like a failed
Yeah.
IVF cycle or a failed IUI. It's like, I know they're both such like judgmental words.
I agree. So if it comes back that you don't get an answer, you have to realize we are literally just checking puzzle pieces. Like each chromosome has thousands of genes. And we will find more reasons for miscarriage. Dr. Latzi at Stanford is working on that. She's doing whole genome sequencing on people that have miscarriages and miscarriages themselves, because just like there's a single gene mutation that causes cystic fibrosis, there's a single gene mutation that causes sickle cell disease, we are going to find mutations for implantation of the embryo. For if you have a mutation here, it's not going to go from week 5 to week 6, right? So I mean, how else do you explain these people that have like 8 and 10 miscarriages and then they have 3 kids, right? What's different? Not the person, it's the embryo.
And even if those chromosomes are normal, because that's sometimes I always have to tell my patients, it very well could be normal when it comes back, but that doesn't tell us anything about when that embryo is growing and developing. There's a lot of things that have to happen. There's lots of folding and dividing and things, and there could be an error. And there are frequently errors.
I think about like the recipe versus the finished dish, right? Like you have the recipe, but as everything actually comes together, it's not always going to go to plan. And also just how much randomness there is. You mentioned balanced translocations earlier. I had a couple where that they did find out they had a balanced translocation after several miscarriages. And we did either 2 or 3 IVF cycles and we could not find a normal embryo. And then waiting to cycle again, she got spontaneously pregnant again. And that was an ongoing. It's like it didn't matter that we had created X number of embryos and hadn't gotten lucky. She got lucky just on her own that time. And we wish that we had more control over things than we actually do.
Yeah, that's a great story. Although I'm just like, oh gosh, poor thing going through all those cycles. But I'm glad that she had her baby. That's amazing.
So what other thing, when people are obviously seeking information, that's the challenge. Like people go down all these rabbit holes on the internet. Like what are some of the most common concerns or questions that you get from your patients when they're coming in to talk about miscarriage?
Absolutely. So it's so easy to blame yourself. You are your own biggest target. It's very frustrating to not have answers when you feel out of control. You just want to find the one thing that you can change.
And people will do whatever you tell them to do. That's the thing. If you had like the magic pill or any of that, like, it's so hard.
Well, I know. So people often ask a lot about immuno testing or autoimmune or this whole field of reproductive immunology. And I just have to say, listen, I'm humble, I'm learning, but the evidence really does not support what's going on in that particular field. I don't do natural killer cell testing. I don't prescribe IVIG or IV interlipids. And I have a whole chapter on that in Not Broken, just saying, you can't say, oh, there's no evidence that it doesn't work. I'm like, no, actually there is, and there's side effects with these things. And so I totally validate and appreciate the desire to want that knowledge and to feel like your body is broken and to seek out people that are going to do a test to tell you something's wrong and give you an intervention. And I totally respect that. And I do have patients that often seek both treatment with me as well as treatment with a reproductive immunologist. But I just have to say that's not a part of my practice. And, let's just really talk about it. Another thing that I see is this part of kind of self-blame and trying to find the reason. So there's a spiral of, oh, well, if I follow this certain diet or if I exercise this certain way or I have this certain supplement, I'm not going to have this pain. Again, I'm not going to have another miscarriage. And so then if somebody like completely cuts out gluten because they read on some Instagram post that gluten is anti-inflammatory, well, yes, if you have celiac disease, you should avoid gluten, but just because some influencer says that you shouldn't have gluten, then it's a spiral. It's a negative thing. So then if you do this, and then you still have another miscarriage, you're like, oh, well, I must have not been good enough. Now I need to restrict even more. And it becomes really self-punishing. So I try to be really thoughtful about that and just talk about balance and everything in moderation and focus on your health. Don't focus on a number on a scale or a perfect diet in air quotes or that type of thing. So it's a lot of kind of nurturing.
Check out our last episode right before this one with Rachel Malik, because she talks all about diet and the misconceptions around nutrition.
And how gluten is okay for most people. So.
And I tell everybody I love all the gluten.
Oh, that's great. I did not say that on purpose. These guys did not pay me to say that.
But what I was going to say is also it's so hard because so much of this field is shaped by personal experience for people. And I know even for me going through infertility treatment, one of my unsuccessful cycles, I mean, again, I was going to do anything. I did hypnosis because I was like, maybe that's it. I'm just not relaxed enough. And I listened to my CDs because I'm old. So I had CDs and this and that. And like, I didn't get pregnant. And I'm like, that hypnosis was such a waste of time. But if that had been the cycle that worked for me, I would be telling everybody like, this is the thing that I did. And that's why I had this cycle. So it's like anything that you try. I mean, there's just that amount of randomness. And so somebody is going to get pregnant doing something, but it doesn't mean that that was the reason that that was the cycle that was successful.
But important question, do you quack when there's certain sounds that happen?
I'm pretty sure I still have my like stack of CDs somewhere because I like in a drawer, and it was all about like letting go of, I mean, I do think it helped me relax, but it gave me one more thing that I felt like I had to do, right? Okay, I'm not doing my affirmations enough. I need to make sure that I'm doing my relaxation CDs and sitting in the room and talking about, I mean, it's all about whether it's helpful for you. And that's what I talk about with acupuncture too for people, although we do have evidence on acupuncture, but I'm also like, if you're needle phobic and the idea of going to an acupuncturist is filling you with dread and anxiety, then don't feel like you have to do it. There's something that, is this going to be positive and healing for you? Or is this going to be just one more thing that you feel like you're having to check off the list, but it's not actually making you feel any better?
Well, and you feel like you're failing again, like you said, like, you know, like I did all these CDs, or maybe, oh, I didn't listen to that one, or I haven't listened to it in a week, then, oh, I failed this. This is why it's happening. So yeah, I think you're exactly right.
It's like three of us have the same brain. We just yeah, I know your listeners can't hear it, but I'm like, yeah, exactly.
Well, then I think about like my spontaneous pregnancy afterwards, like was when I was training for my first marathon. And I think about all the weeks I laid on the couch and did nothing and like try it. And I did. I beat myself up over exercising. I thought that I had done all this stuff and that's why embryos hadn't implanted. And then I was like, I can go back. And that was the weekend I did an 18-miler. So I know like implantation happened at that time, but you want to control things you can't control. And so that's what's so hard is like anyone that publishes the guidebook that you're like, yep, tell me what to do and I will do it, because that's how we're wired.
And you want an answer. So we mentioned this with unexplained infertility too, that, and how many patients do you have that have had an HSG and it's normal and they cry or they're super upset because they're like, well, what is it? What is happening? Why am I having all these miscarriages? Why can't I get pregnant? What's the answer? Because at least then I know and I can put a label on it and I can then focus on it. You have something to hold on to.
I know it's kind of crazy with pregnancy loss, how happy you are when you find a septum, because you're like, okay, we found something that's going to be a surgical repair. And it's not like a huge, scary surgery. Usually it's something very, achievable. How do you help people feel supported emotionally to try again when you haven't been able to change anything?
Just trying again is changing everything.
That's true.
It's a brand new egg. It's a brand new sperm. It's a brand new embryo.
Oh, that's such a good point.
That is a really good way to think about it.
I'm also very careful when I do find something, when I do find a septum, and I celebrate with the patient too. I'm so glad that we found this. By the way, you can still have a miscarriage after I fix it. And they're like, darn it, like what?
Well, like after putting in a normal embryo, miscarriages after PGT are so hard.
Absolutely. I feel like in the beginning, when we really started offering IVF with chromosomal screening as a way to decrease the risk of miscarriage, a lot of people in the field, I mean, this is like 10 years ago, a lot of people in the field really embraced it because 80-90% of people with miscarriages, you test the tissue and it is a chromosome issue. So you're like, great. If that's the most common cause of miscarriage, then we're going to fix it by doing this intervention. And so a lot of people embraced it. And I do remember very kind of early in my career, just being so excited and like sharing this with the patient. And I'll remember always that first patient that had a miscarriage with a tested embryo. And she was so mad at me. And it's okay. Like, we're big targets and that's totally fine. And I was just like, wow, I think that I need to counsel a little bit better, that it will decrease the risk of miscarriage, but it's not zero. So, for example, if someone's 40 years old and they get pregnant without assistance, I don't say naturally anymore, they get pregnant without assistance, the chance of miscarriage is honestly 50%. People don't talk about that, but it's pretty high. Or 50% glass half full baby. But if they do IVF and they transfer a tested embryo, their chance of miscarriage is 10%. So that's a dramatic difference. There is a decrease, but it's just not zero. And I wish it was.
I can't remember if it's in your book or somewhere else, but where they show the stats for like even someone that's had 5 miscarriages, like that next time that they get pregnant, how it's still statistically more likely that that's going to be an ongoing pregnancy. Because I think in people's minds, if they've had recurrent loss when they get pregnant, they're probably thinking, well, the chance of this working is only 10%. That's really not true. Like, even if it is untested, even if they are older, they still have a pretty reasonable chance of this being a successful, well, I shouldn't say successful either, of this being an ongoing pregnancy that does end in taking home a baby.
Yeah, you're mentioning my favorite study. It's from Brigham, is the first author, and it's from almost 20 years ago. And it is in my book, and it is something that I talk about in every talk, and I show the graph. And the reason it's so unique is because we have so many interventions, you're not going to get this data anymore. And so this was like before people would ever think about doing IVF for recurrent loss. And so it was just following people in a fertility clinic, and even person with an egg in uterus was 40 years old, had 5 miscarriages. Their 6th pregnancy, there was a 50% chance of having a baby.
Wow.
I love that. But when you're that person who's had 3 miscarriages, you're 0 for 3. You're like, I don't believe you.
Yeah. Yeah. And that's hard too, because then you've also been through 3 or 4 or 5 miscarriages too, which are, each one is so hard and devastating. What about, so this is really, really common. And I think it's probably my number one question I get from people is, what about my progesterone?
Progesterone is amazing. It's the best immune modulator in our body. It literally shifts our immune system to a more receptive state, more Th2, if you want to get really nerdy, dominant immune cells. Love progesterone. But most people don't need to supplement. And you can. I give it to a lot of my patients who have recurrent miscarriage, but most people honestly don't need it. I sort of say, like, I probably give it to 100 people and I'm helping 3. It's just that I don't know which 3 people need it. So I give it out way more than I need to. Another thing is, it's really important to realize that you can't use blood tests to tell if you need it or not. The way our ovaries make it after ovulation in the luteal phase is it's very pulsatile. So it's kind of like if you check it on cycle day 21 at 11 a.m., it might be like 7. And you're like, oh my God, it's so low. But you could check it 2 hours later and it'll be 21. And you'd be like, see, it's fine. And then also when you check it in pregnancy, what's really hard is if a pregnancy is already starting to not be a very healthy pregnancy, it's on its way to miscarriage, it's not going to stimulate the ovaries to make enough progesterone. It's a very symbiotic relationship. And so a low progesterone at the same time as having a miscarriage, it's not necessarily the chicken or the egg. It's not necessarily the low progesterone that caused it. It's the pregnancy that didn't stimulate the ovaries to do what they need to do. A lot of providers just will check it. You know, a lot of patients ask for it. And I'll just say, you know, honestly, it's just going to confuse us. I think we can just do the supplement. I don't think you need to keep checking it. I wish it was the answer that you wanted it to be, because everyone's looking for that answer. But like, let me explain the physiology to you. Let me explain why I don't always check it in natural cycles. And let's talk about the pros and cons of taking it.
And also explaining it so people understand that it wasn't that if someone had given them progesterone before, that pregnancy would have been successful. Because I feel like that's another thing. People are like, why didn't anyone give me progesterone when they, you know, and so trying to explain. And there's so much blame about every possible thing. And so at least we can let that one go to be like, hey, this was more of a symptom for what was going on. This wasn't the cause of what was going on.
Yeah, I like that. A symptom rather than a cause. I do talk to people about like a common fear is if I take it, is it going to make me hold on to a pregnancy that's not healthy?
Mm-hmm.
And it's not that powerful. Like if that pregnancy is not meant to continue, I just think about it like if there is an embryo with the right genetics, progesterone could maybe help the environment a little bit, but it's not going to make or break whether or not you have a baby.
Perfect. We've covered a lot of the medical stuff. What do you tell people in terms of lifestyle? I mean, I know a lot, but in the couple minutes we have left, like what are your key things that you really recommend that everybody think about?
Again, I have a whole chapter. I love talking about this kind of stuff on my YouTube channel too. I think about being healthy and being kind to yourself and self-care. We all know that we should eat well and we should eat majority of fresh fruits and vegetables and protein, not too much animal protein, and just have a well-balanced diet. But if you can do that 80% of the time, perfection. That ice cream every once in a while tastes great. That glass of wine every once in a while when you're trying to conceive, awesome. Should we be drinking every day? No. Should we be, having ice cream 3 times a day? No. So it's just kind of like being kind to yourself and focus on health. And then exercise. Oh my gosh, every person is different. Every pregnancy is different. I don't like people pushing their body to extremes. As soon as I say that, though, someone's like, well, Serena Williams won the Australian Open in her first trimester. So I'm like, you're right. But I still think that if we're pushing ourselves to the point where we're having a runner's high or endorphin rush, we're pumping out cortisol and that's shifting us away from reproduction. But that does not mean absolutely no exercise because moving your body is good for mental health and your overall well-being. So moderation, of course we shouldn't smoke or vape. And I think about just taking a prenatal vitamin. We are all in the Pacific Northwest. Everybody needs vitamin D.
For sure.
Does someone need to load up on supplements and take everything from, GNC? No. And so it's just moderation. And then let's talk about it with each individual patient.
Yeah. And one thing to mention about the exercise piece too is your run or your walk did not cause your miscarriage either. Cause that's one that happens a lot too, is they'll come in and it's because I went for a run and it's like, no, that's not what it was. So I can say this with confidence that none of my patients caused their miscarriage.
Agree, 100%.
And one thing before we kind of wrap up this section is I just wanted to touch in, because I get questions about this a lot too, is the anticoagulants, the aspirins and the MTHFRs and the factor fives, because that I think is second to progesterone in questions I get.
Do you have another 3 hours? I mean, how do I tackle that? Antiphospholipid syndrome is the one immune issue that can be associated with blood clotting issues that we should screen for when someone has recurrent miscarriage. If someone tests positive for it, aspirin and low-dose heparin or Lovenox are 2 interventions that can help increase the chance of live birth in that person with diagnosed antiphospholipid syndrome. MTHFR is a mutation that can lead to disrupted folic acid use, and that's really important in DNA replication. But just because you have an MTHFR mutation, that does not mean that you have issues with your folate or your DNA, because 40 to 50% of the population has a mutation for MTHFR. I think that taking a good prenatal vitamin and maybe some folic acid B complex, talk to your doctor about what's right for you, you're going to be meeting your needs. And just to say that an MTHFR mutation causes miscarriage, it just doesn't make sense with just the numbers and kind of the population. And I do have a lot of studies and I talk about that because I know that there's a lot of controversy, but I go over that really in detail in my book. When I first started training, this is the third part of your question about sort of well, should we test for these mutations or things that you're born with that could cause you to have an increased risk of blood clots? So things like factor V Leiden or prothrombin gene mutation. And when I was in residency, we used to routinely check patients with recurrent miscarriage for those things. But hands down, the data does not support it, no matter which way you look at it. And the American Society of Reproductive Medicine ACOG, Hematology Society does not recommend routine testing because people who have those issues do not have a higher chance of miscarriage, and treating with unnecessary heparin does not decrease miscarriage. It's like, I want to just read everything in my book or like the evidence, but in general, you should talk to your doctor about it. But unless you have a personal or family history of blood clots, you don't routinely check for those things. I do talk about aspirin with a lot of my patients. It's an antiplatelet. You can get it from the drugstore. It's the first line treatment for antiphospholipid syndrome. There could be antibodies out there that we don't know to test for yet. It's considered empiric treatment, just like progesterone for a lot of people, meaning like there's not like a specific diagnosis, but definitely talk to your doctor because it's antiplatelet. You don't clot as much. Like, tell your doctor if you're taking it. Because I think sometimes people just think, oh, it's at the drugstore, it doesn't matter. And then, we're doing egg retrievals on people or we're doing a hysteroscopy and we just need to know what people are taking. So.
And the same thing for anyone that's seen, a naturopath, or they're taking herbs, or there's so many people are getting sources from a lot of places now. And we want to know what people are on so that we can make sure that we're not concerned about interactions or side effects.
Exactly.
That was awesome. You did 3 hours and 3 minutes. So that was perfect to squeeze it all in. And we'll definitely be posting links for your book. We know this is just a dipping the toes in the pond of what we could be talking about.
Laura, where can we find you?
The most central place is my website, drlorashahine.com. But I have a YouTube channel. My books are on Amazon, and I love Instagram. I love TikTok. I love educating on all social media platforms. So you can find me there, Twitter, anywhere at Dr. Laura Shaheen.
We did a good job hitting the most common things that we hear in the highlights. And I so appreciate you coming on and talking with us today.
I appreciate the opportunity. Thank you so much, you guys.
And one last note before we leave, it is Pregnancy and Infant Loss Awareness Month. So if you have experienced a pregnancy or an infant loss, we see you and we're here with you and we grieve with you and we support you.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.